Psychiatry and Psychology audiobook for USMLE Step 1. Let's start our chapter with classical conditioning, which is a type of learning in which a natural response, like salivation, is elicited by a conditioned, or learned, stimulus such as a bell, and this bell was previously presented together with an unconditioned stimulus, which in this case was food, and this form of learning usually elicits involuntary responses, as demonstrated by Pavlov's classical experiments with dogs, where ringing the bell eventually provoked salivation, even without the presence of food. Are you following me? Now let's move to operant conditioning, which is a kind of learning in which a particular action is elicited because it leads to either a punishment or a reward, and this type of conditioning usually elicits voluntary responses, where reinforcement happens when a target behavior, or response, is followed by a desired reward, which is called positive reinforcement, or by the removal of an aversive stimulus, known as negative reinforcement. While punishment is a repeated application of an aversive stimulus, which is positive punishment, or removing a desired reward, which is negative punishment. Aim to extinguish unwanted behavior. In Skinner's operant conditioning quadrants, the actions can be summarized like this: when you add a stimulus or remove a stimulus, and either increase or decrease the behavior, you get 4 outcomes. Now listen carefully, because in this framework, positive reinforcement refers to adding a stimulus to increase behavior, while negative reinforcement means removing a stimulus to increase behavior, and on the other hand, positive punishment involves adding a stimulus to decrease behavior, while negative punishment involves removing a stimulus to decrease behavior. Now let's continue, because extinction means the discontinuation of reinforcement, whether positive or negative, and this eventually eliminates the behavior, and this process can occur both in operant and classical conditioning. Now listen carefully as we shift to transference and countertransference, because in transference, the patient projects feelings about formative or other important persons onto the physician. For example, the psychiatrist might be seen as a parent, and in countertransference, it's the physician who projects feelings about formative or other important persons onto the patient, such as when the patient reminds the physician of a younger sibling. Are you ready to move forward? Now we come to ego defenses, which include thoughts and behaviors, whether voluntary or involuntary, that are used to resolve conflict and prevent undesirable feelings, such as anxiety or depression, and under the category of immature defenses. Now let's talk about acting out, which involves subconsciously coping with stressors or emotional conflict by using actions instead of reflections or feelings, and for example, a patient might skip therapy appointments after feeling deep discomfort from dealing with his past, while denial, another immature defense, involves avoiding the awareness of some painful reality, like a patient with cancer who continues to plan a full-time work schedule even after being warned about significant fatigue during chemotherapy. Now listen carefully as we explain displacement, which is the redirection of emotions or impulses to a neutral person or object, and this is different from projection. So for instance, after being reprimanded by her principal, a frustrated teacher returns home and criticizes her wife's cooking instead of confronting the principal directly, and dissociation, which is also important, involves a temporary and drastic change in personality, memory, consciousness, or motor behavior in order to avoid emotional stress, and a patient experiencing this may have incomplete or no memory of a traumatic event. To illustrate dissociation clearly, imagine a survivor of sexual abuse who sees the abuser and suddenly becomes numb and detached. Now let's talk about fixation, which means partially remaining at a more childish level of development, and this is different from regression. For example, when a college student continues to suck her thumb while studying for stressful exams. Let's continue with idealization, which is when someone expresses extremely positive thoughts about themselves or others, while deliberately or unconsciously ignoring any negative thoughts, and a clear example is a patient who boasts about his physician and his accomplishments, while completely overlooking any flaws, painting an unrealistically perfect picture. Now let's move on to identification, which involves the largely unconscious assumption of characteristics, qualities, or traits of another person or group, and this can be seen when a resident starts putting her stethoscope in her pocket like her favorite attending, instead of wearing it around her neck like she used to, reflecting how admiration can shape unconscious imitation. Now listen carefully, because intellectualization is the use of facts and logic to emotionally distance oneself from a stressful situation, and this is evident when a patient diagnosed with cancer talks in detail about the pathophysiology of the disease, using scientific knowledge as a shield to avoid confronting emotional distress directly, keeping the heart out of the matter. Next comes isolation of affect, which is the act of separating feelings from ideas and events, and a striking example would be someone describing a murder in graphic detail with no emotional response. Now let's talk about passive aggression, which means demonstrating hostile feelings in a non-confrontational way, often showing indirect opposition, and this shows up in a disgruntled employee who is repeatedly late to work, yet refuses to admit that it is a way to get back at the manager. Are you ready? Because projection involves attributing an unacceptable internal impulse to an external source, and this is different from displacement, so when a man who wants to cheat on his wife accuses his wife of being unfaithful. Now listen carefully as we explain rationalization, which means asserting plausible explanations for events that actually happen for other reasons, usually to avoid self-blame, and a classic case would be when an employee who was recently fired says the job was not important anyway. Let's move on to reaction formation, where a warded-off idea or feeling is replaced with an emphasis on its opposite, and this is different from sublimation. So for example, a stepfather who resents a child might treat the child with excessive nurturing and overprotection, hiding resentment beneath an exaggerated show of care. Now let's talk about regression, which involves involuntarily turning back the maturational clock to behaviors previously demonstrated under stress, and this is different from fixation. So imagine a previously toilet-trained child who begins bedwetting again after the birth of a sibling. Are you following me? Because repression means involuntarily withholding an idea or feeling from conscious awareness, and it contrasts with suppression. So for example, a 20-year-old who doesn't remember going to counseling during his parents' divorce 10 years earlier. Now let's discuss splitting, which involves believing that people are either all good or all bad at different times, due to an intolerance of ambiguity, and this defense is common in borderline personality disorder. Remember borders split, so when a patient says all the nurses are cold and insensitive, but the physicians are warm and friendly. Now listen carefully as we talk about mature defenses, starting with sublimation, which means replacing an unacceptable wish with a socially acceptable course of action that is similar to the original wish, and unlike reaction formation, this allows for productive redirection, like when a teenager's aggression toward her parents is channeled into excelling in sports, turning frustration into achievement. Next is altruism, which involves alleviating negative feelings through unsolicited generosity, bringing gratification, and unlike reaction formation, it reflects mature emotional coping, as in the case of a mafia boss making a large donation to charity. Now let's go on to suppression, which means intentionally withholding an idea or feeling from conscious awareness, and it is different from repression, because it is temporary and voluntary, so when an athlete focuses on other tasks to avoid worrying about an important upcoming match. Finally, we come to humor, which is the light-hearted expression of uncomfortable feelings in order to shift internal focus away from distress, and a perfect example is a nervous medical student who jokes about the boards. And remember, mature adults wear a sash. Grief is a natural feeling that occurs in response to the death of a loved one, and symptoms, as well as the trajectory, vary for each individual, are specific to each loss, and do not follow a fixed series of stages. In addition to guilt, sadness, and yearning, patients may experience somatic symptoms, hallucinations of the deceased, and transient episodes of wishing they had died with, or instead of, their loved one. Now let's talk about the course of this emotional process, because typical acute grief is time-limited, meaning adaptations usually occur within 6 months, and it is not considered a disorder. However, when grief remains intense, persistent, and prolonged, lasting at least 6 to 12 months, and significantly impairs functioning, it may be diagnosed as prolonged grief disorder. This diagnosis only applies if the grief is inconsistent with the patient's cultural or religious norms, and importantly, does not meet criteria for another disorder, like major depressive disorder, or MDD. Now listen carefully as we shift to child development, because normal infant and child development is tracked using milestone dates, which are only approximations, and vary by source. Children who do not meet these milestones may need an assessment for potential developmental delay, so it's important to stay alert to these benchmarks. In the infant stage, from 0 to 12 months, we use the phrase, parents start observing, to remember the key skills. Primitive reflexes disappear, like Morrow, Rooting, Palmer, and Babinski, and posture develops as the infant lifts the head up while prone by 1 month, rolls and sits by 6 months, crawls by 8 months, stands by 10 months, and walks by 12 to 18 months. You should remember this: the child picks, passes toys hand to hand by 6 to 9 months, and develops a pincer grasp by 10 months, while also pointing to objects by 12 months. Socially, there's a social smile by 2 months, stranger anxiety by 6 months, and separation anxiety by 9 months. Orients to voice by 4 months, then to name and gestures by 9 months, object permanence appears by 9 months, and oratory emerges with mama and dada said by 10 months. Now let's talk about toddlers, aged 12 to 36 months, and the phrase to remember here is, child rearing working, because they begin to cruise and take their first steps by 12 months, climb stairs by 18 months, and stack cubes, with the number equaling age in years multiplied by 3. They begin to feed themselves with cutlery, like a fork and spoon, by 20 months, and kick a ball by 24 months. Socially, they engage in parallel play between 24 to 36 months, and show rapprochement, meaning they move away from and return to the parent by around 24 months. Also, the realization of core gender identity forms by 36 months, which is a key milestone. Verbally, toddlers use 50 to 200 words by age 2, and over 300 words by age 3. Are you ready for preschool milestones? Because from 3 to 5 years, we say, don't forget, they're still learning. In terms of motor skills, they drive a tricycle by 3 years, draw lines or circles, and create stick figures by 4 years, showing more advanced fine motor coordination. They demonstrate dexterity by hopping on 1 foot by 4 years, and by 5 years, they use buttons or zippers and groom themselves independently. Socially, they gain freedom, as they can comfortably spend part of the day away from a parent by age 3, and they develop friendships, engaging in cooperative play and often having imaginary friends by age 4. Now listen carefully, because language also flourishes. By age 3 they understand about 1,000 words, using complete sentences and prepositions by age 4, and by that time, they can tell detailed stories, becoming little storytellers with rich imagination and expressive skills. Now listen carefully, because all cases of suspected child abuse must be reported to local child protective services. And as we explore this topic, let's begin with the signs and epidemiology of different forms of abuse. Neglect includes poor hygiene, malnutrition, withdrawn affect, impaired social or emotional development, and failure to thrive, due to failure to provide a child with adequate food, shelter, supervision, education, and affection. It is the most common form of child maltreatment. Now let's talk about physical abuse, which refers to non-accidental trauma, such as fractures, bruises, or burns. These injuries are often in different stages of healing, or in patterns resembling possible implements of injury. You should remember this: physical abuse includes abusive head trauma, also known as shaken baby syndrome, which is characterized by subdural hematomas or retinal hemorrhages. Caregivers may delay seeking medical attention for the child, or provide explanations inconsistent with the child's developmental stage or pattern of injury. About 40% of deaths related to child abuse or neglect occur in children less than 1 year old. Are you following me? Because next is sexual abuse, which may involve STI, UTI, and genital, anal, or oral trauma. Most often, there are no physical signs, so sexual abuse should not be excluded from a differential diagnosis in the absence of physical trauma. Children often exhibit sexual knowledge or behavior incongruent with their age. Sexual abuse peaks in incidence 9 to 12 years old. Now let's talk about emotional abuse, where babies or young children may lack a bond with the caregiver, but may be overly affectionate with less familiar adults. They may be aggressive towards children and animals, or unusually anxious. Older children are often emotionally labile, prone to angry outbursts, and may distance themselves from caregivers and other children. They can experience vague somatic symptoms, for which a medical cause cannot be found. Approximately 80% of young adult victims of child emotional abuse meet the criteria for at least one psychiatric illness by age 21. Finally, let's discuss vulnerable child syndrome, where parents misperceive the child as especially susceptible to illness or injury, unlike factitious disorder imposed on another. Now listen carefully, this usually follows a child's serious illness or life-threatening event, and can result in missed school, or overuse of medical services. Just imagine the child wrapped in bubble wrap. Childhood and early onset disorders present unique challenges, and we begin with attention deficit hyperactivity disorder. It has onset before age 12, but diagnosis can only be established after age 4. It is characterized by hyperactivity, impulsivity, and inattention in 2 or more settings, such as school, home, or places of worship. Intelligence is normal, but this often coexists with difficulties in school. The condition frequently persists into adulthood, and it commonly overlaps with other behavioral, cognitive, or developmental disorders. Treatment includes stimulants like methylphenidate, with or without behavioral therapy, and alternatives such as atomoxetine and alpha-2 agonists like clonidine or guanfacine. Now let's talk about autism spectrum disorder, which begins in early childhood. This includes social and communication deficits, repetitive or ritualized behaviors, and restricted interests. It may be accompanied by intellectual disability, or in some cases, above-average abilities in specific skills such as music. It is more common in males and is associated with increased head and brain size. Moving on, conduct disorder involves repetitive, pervasive behavior that violates societal norms or basic rights of others, such as aggression toward people and animals, destruction of property, or theft. After age 18, this is often reclassified as antisocial personality disorder. Remember, conduct equals children, and antisocial equals adults. Treatment includes psychotherapy, such as cognitive behavioral therapy. Now listen carefully, disruptive mood dysregulation disorder begins before age 10 and is diagnosed after age 6. It features severe, recurrent temper outbursts that are out of proportion to the situation. The child is persistently angry and irritable between outbursts. Treatment options include CBT, stimulants, and antipsychotics. Intellectual disability, by contrast, involves global cognitive deficits, unlike specific learning disorder, and affects reasoning, memory, abstract thinking, judgment, language, and learning. Adaptive functioning is impaired, which leads to major challenges in education, employment, communication, socialization, and independence. Treatment consists of psychotherapy, occupational therapy, and special education. Are you following me? Because intermittent explosive disorder typically begins after age 6. It presents with recurrent verbal or physical outbursts, reflecting a failure to control aggressive impulses. These outbursts last less than 30 minutes, are out of proportion to provocation, and may cause legal, financial, or social problems. Episodes are not premeditated, may bring immediate relief, and are followed by remorse. Treatment includes psychotherapy and SSRIs. Oppositional defiant disorder, on the other hand, shows a pattern of anger and irritability, with argumentative, vindictive, and defiant behavior toward authority figures, lasting at least 6 months. Treatment is psychotherapy, including CBT. Now let's talk about selective mutism, which starts before age 5. It is an anxiety disorder that lasts for at least 1 month, where the child refrains from speaking in certain situations, despite speaking normally in others. Speech and language development are not typically impaired. It interferes with social, academic, and occupational functioning, and often coexists with social anxiety disorder. Treatment includes behavioral, family, and play therapy, along with SSRIs. Separation anxiety disorder involves overwhelming fear of separation from home or attachment figures, lasting 4 weeks or more. While it can be normal up to age 3 or 4, in older children it may cause factitious physical complaints to avoid school. Treatment includes CBT, play therapy, and family therapy. Now listen closely, specific learning disorder starts during school-age years. It presents as an inability to acquire or use information from a specific subject, like math, reading, or writing, at a level expected for age, despite focused intervention for at least 6 months. General intelligence remains normal that distinguishes it from intellectual disability. Treatment includes academic support, counseling, and extracurricular activities. Finally, Tourette's syndrome begins before age 18 and includes sudden, recurrent, non-rhythmic, stereotyped motor tics like grimacing or shrugging, and vocal tics like grunting or throat clearing, lasting more than 1 year. Coprolalia, or involuntary obscene speech, may occur in some patients. It is associated with OCD and ADHD. Treatment includes psychoeducation and behavioral therapy, and for severe intractable and distressing tics, options include tetrabenazine, antipsychotics, or alpha-2 agonists. You know what orientation means, right? It refers to the patient's ability to know the date and time, where they are, and who they are. The order of loss typically follows a sequence: first time, then place, and finally person. Common causes of loss of orientation include alcohol, drugs, fluid and electrolyte imbalance, head trauma, hypoglycemia, infection, nutritional deficiencies, and hypoxia. Now, moving on to amnesias. Retrograde amnesia is defined as the inability to remember things that occurred before a central nervous system insult, while anterograde amnesia is the inability to remember things that occurred after the CNS insult, meaning there's an impaired acquisition of new memory. Now let's talk about Korsakoff syndrome. This condition presents with amnesia, where anterograde memory loss is greater than retrograde, and it also causes disorientation. It is caused by vitamin B1 deficiency and is associated with disruption and destruction of the limbic system, especially the mammillary bodies and the anterior thalamus. You should remember, it is typically seen in chronic alcohol use as a late neuropsychiatric manifestation of Wernicke encephalopathy. Confabulations, or the creation of false memories without the intention to deceive, are characteristic of this syndrome. Now let's turn our attention to dissociative disorders, beginning with depersonalization or derealization disorder. This involves persistent feelings of detachment or estrangement, either from one's own body, thoughts, perceptions, and actions, known as depersonalization, or from one's environment, known as derealization. Importantly, reality testing remains intact, which distinguishes it from psychosis. Now listen carefully. Dissociative amnesia refers to the inability to recall important personal information, typically following severe trauma or stress. This may also be accompanied by dissociative fugue, which is defined as abrupt and unexpected traveling away from home. Next, we have dissociative identity disorder, formerly called multiple personality disorder. It involves the presence of 2 or more distinct identities or personality states, each typically associated with distinct memories and behavioral patterns. It is more common in females and is associated with a history of sexual abuse, post-traumatic stress disorder, depression, substance use, borderline personality disorder, and somatic symptom disorders. Now let's shift to delirium, which is marked by a waxing and waning level of consciousness, with acute onset, reduced attention span, and a decreased level of arousal. Delirium is characterized by disorganized thinking, hallucinations that are often visual, misperceptions such as illusions, disturbance in the sleep-wake cycle, cognitive dysfunction, and agitation. Importantly, it is reversible. It is usually secondary to another identifiable illness, such as central nervous system disease, infection, trauma, substance use or withdrawal, metabolic or electrolyte disturbances, hemorrhage or urinary and fecal retention. It may also be triggered by medications, particularly anticholinergics, especially in older adults. Now listen carefully. Delirium is the most common presentation of altered mental status in the inpatient setting, particularly in the intensive care unit or during prolonged hospital stays. Remember this: delirium equals changes in sensorium. EEG may reveal diffuse background rhythm slowing. Treatment involves identifying and managing the underlying condition. Orientation protocols are helpful, such as keeping a clock or calendar nearby. Addressing sleep disturbances and increasing cognitive stimulation can help manage symptoms. Antipsychotics like haloperidol may be used as needed, but it's critical to avoid unnecessary restraints and drugs that may worsen delirium, such as anticholinergics, benzodiazepines, and opioids. Psychosis, which is defined as a distorted perception of reality. It is characterized by delusions, hallucinations, and disorganized thought or speech. Psychosis can occur in patients with primary psychiatric illnesses, but it can also arise from another medical condition, or be secondary to substance or medication use. Now listen carefully. Delusions are false, fixed, idiosyncratic beliefs that persist despite clear evidence to the contrary. These beliefs are not typical of a person's culture or religion. For example, a patient may believe others are reading his thoughts. Types of delusions include erotomanic, grandiose, jealous, persecutory, somatic, mixed, and unspecified types. Now let's move on to disorganized thought. In this case, a person's speech may be incoherent, sometimes described as a word salad, or it may be tangential, or derailed, which we also call loose associations. Next, we turn to hallucinations, which are perceptions that occur in the absence of any external stimuli, such as seeing a light that is not actually present. There are different types. First, auditory hallucinations are more commonly due to psychiatric illnesses like schizophrenia than neurological diseases. Second, visual hallucinations are more often associated with neurological disease, such as dementia, or with delirium or drug intoxication, rather than psychiatric illness. Now listen carefully. Tactile hallucinations are often seen in alcohol withdrawal and stimulant use. A classic example is the cocaine crawlies, a type of delusional parasitosis. Olfactory hallucinations often present as auras in temporal lobe epilepsy, with sensations like burning rubber, and they may also occur in brain tumors. Gustatory hallucinations are rare, but they can be seen in epilepsy. There are also sleep-related hallucinations. Hypnagogic ones occur while falling asleep, and are sometimes seen in narcolepsy, while hypnopompic hallucinations occur while waking from sleep. To help you remember, think, get pumped up in the morning. Be sure to contrast hallucinations with illusions, which are misperceptions of real external stimuli, such as mistaking a shadow for a black cat. Now let's talk about mood disorders. These are characterized by abnormal ranges of mood or internal emotional states, along with a loss of control over them. The severity of these moods leads to distress and impairs social and occupational functioning. Mood disorders include major depressive disorder, bipolar disorder, dysthymic disorder, and cyclothymic disorder. Importantly, psychotic features such as delusions, hallucinations, and disorganized speech or behavior can sometimes be superimposed during mood episodes, except in the case of hypomania. Now, let's break this down a little more, and follow the sequence carefully. Mania, hypomania, euthymia, dysthymia, and depression all represent points along the mood spectrum. Now listen carefully. Major depressive episodes, or MDEs, may occur with psychotic features. In bipolar I disorder, only one episode of mania is required for diagnosis. Psychotic features are possible during manic or depressive episodes. In contrast, bipolar II disorder requires at least one episode of hypomania and one major depressive episode. Here, psychotic features can occur during the depressive episode, but not during hypomania. Now let's consider schizoaffective disorder. In this case, psychosis overlaps with mood episodes but must also occur by itself for more than 2 weeks, meaning psychotic symptoms persist outside mood changes. Finally, in mood disorders with psychotic features, the psychosis only occurs during the mood episodes, and never independently. Now let's talk about schizophrenia spectrum disorders, starting with schizophrenia itself. It is a chronic illness that causes profound functional impairment. The symptoms are grouped into 3 broad categories. First, positive symptoms refer to excessive or distorted functioning, such as hallucinations, delusions, unusual thought processes, disorganized speech, and bizarre behavior. Second, negative symptoms represent diminished functioning, including blunted affect, apathy, anhedonia, alogia, and asocial behavior. Third, cognitive symptoms involve a reduced ability to understand or make plans, along with diminished working memory and inattention. Are you following me? Now listen carefully. Diagnosis requires at least 2 active symptoms, and at least one must be from the first 3: delusions, hallucinations, often auditory, or disorganized speech. The remaining possible symptoms include disorganized or catatonic behavior and negative symptoms. Schizophrenia is associated with altered dopaminergic activity, increased serotonergic activity, and reduced dendritic branching. Brain imaging may show ventriculomegaly. Lifetime prevalence is about 1.5%, with males affected more than females. It typically presents earlier in males, in the late teens to early 20s, and later in females, in the late 20s to early 30s. Importantly, suicide risk is increased. You should remember this: heavy cannabis use during adolescence is associated with increased incidence and a worsened course of psychotic, mood, and anxiety disorders. First-line treatment usually involves atypical antipsychotics such as risperidone. While positive symptoms may resolve with treatment, negative symptoms often persist. For diagnosis, symptoms must have been present for at least 6 months, including at least 1 month of active symptoms during that period. Are you still with me? Let's now differentiate related conditions. Brief psychotic disorder involves at least one positive symptom, lasting between 1 day and 1 month, and is usually stress-related. Schizophreniform disorder involves at least 2 symptoms, lasting from 1 to 6 months. Schizoaffective disorder shares features with both schizophrenia and mood disorders, such as major depressive disorder or bipolar disorder. The key diagnostic point is that psychotic symptoms must be present for at least 2 weeks without any manic or depressive episodes. This is what differentiates it from mood disorder with psychotic features. Now listen carefully. Delusional disorder involves 1 or more delusions lasting longer than 1 month. There is no mood disorder or other psychotic symptoms present. Although daily functioning, including socialization, may be affected by the fixed pathological belief, other aspects of life remain largely unaffected. This disorder can also be shared by people in close relationships, a condition known as folie à deux. Let's also mention schizotypal personality disorder, which falls under cluster A personality disorders but is considered part of the schizophrenia spectrum. It may involve brief psychotic episodes, such as delusions, but these are less frequent and less severe than in schizophrenia. We arrive to discuss about the manic episode. This is defined as a distinct period of abnormally and persistently elevated, expansive, or irritable mood, along with increased activity or energy. For diagnosis, the symptoms must cause marked functional impairment and include at least 3 of the following for 1 week, or any duration if hospitalization is required. These features can be remembered by the mnemonic dig fast. D stands for distractibility, I for impulsivity or indiscretion, seeking pleasure without regard to consequences. G is for grandiosity or inflated self-esteem, F for flight of ideas or racing thoughts. A stands for increased goal-directed activity or psychomotor agitation, S for decreased need for sleep, and T for talkativeness or pressured speech. Now let's talk about the hypomanic episode. It is similar to a manic episode, but with one important distinction: the mood disturbance is not severe enough to cause marked impairment in social or occupational functioning, and it doesn't require hospitalization. However, abnormally increased activity or energy is usually present. Psychotic features are absent. For diagnosis, the episode must last at least 4 consecutive days. Are you following me? Now listen carefully. Bipolar disorder comes in 2 types. Bipolar I disorder requires just one type of episode, at least one manic episode, with or without a hypomanic or depressive episode, and these episodes may be separated by any length of time. Bipolar II disorder, on the other hand, requires 2 types of episodes, one hypomanic and one depressive episode, but no history of manic episodes. In both types, the patient's mood and functioning usually return to normal between episodes. However, you should remember this: using antidepressants can destabilize mood, and the risk of suicide is high. Now let's talk treatment. atypical antipsychotics and mood stabilizers such as lithium, lamotrigine, valproate, and carbamazepine are typically used. Cyclothymic disorder is considered a milder form of bipolar disorder. It involves fluctuations between mild depressive and hypomanic symptoms. To make the diagnosis, symptoms must be present for at least 2 years, and for at least half of the time, with any remission lasting no more than 2 months. Are you with me so far? Let's now move on to major depressive disorder. It consists of recurrent episodes that last at least 2 weeks, and are characterized by at least 5 of 9 diagnostic symptoms. These must include either depressed mood or anhedonia, which is a loss of interest or pleasure, or irritability in children. The symptoms can be remembered using the mnemonic SIG, ECAPS. That's sleep disturbances, decreased interest in pleasurable activities, guilt or feelings of worthlessness, reduced energy, decreased concentration, appetite or weight changes, psychomotor retardation or agitation, and suicidal ideation. Now listen carefully. Before making a diagnosis, it is important to screen for any previous manic or hypomanic episodes, to rule out bipolar disorder. First-line treatment includes cognitive behavioral therapy and SSRIs. Alternatives include SNRIs, mirtazapine, bupropion, electroconvulsive therapy, and ketamine. Keep in mind that responses to significant loss, such as bereavement, natural disaster, or disability, may resemble a depressive episode. However, the diagnosis of major depressive disorder is only made if full criteria are met. Now let's talk about MDD with psychotic features. This is when major depressive disorder occurs along with hallucinations or delusions. These psychotic features are usually mood congruent, meaning they reflect depressive themes such as inadequacy, guilt, punishment, nihilism, disease, or death. Importantly, the psychotic features occur only during the major depressive episode, unlike in schizoaffective disorder. Treatment involves an antidepressant along with an atypical antipsychotic, or electroconvulsive therapy. Now moving on, persistent depressive disorder, also known as dysthymia, is often milder than major depressive disorder. It involves at least 2 depressive symptoms lasting for 2 years or more in adults, and 1 year in children, with any remission lasting no longer than 2 months. Then we have MDD with seasonal pattern, formerly called seasonal affective disorder. This condition is characterized by major depressive episodes that occur only during a particular season, usually winter, and this pattern must be present for at least 2 consecutive years, and in most years across the patient's lifetime. Atypical symptoms are common, and treatment includes standard therapies for major depressive disorder along with light therapy. Finally, let's discuss depression with atypical features. This subtype is marked by mood reactivity, meaning transient improvement in response to a positive event, along with hypersomnia, hyperphagia, and leaden paralysis, a heavy feeling in the arms and legs. It also includes long-standing sensitivity to interpersonal rejection. This is actually the most common subtype of depression. Treatment of choice includes cognitive behavioral therapy and SSRIs. MAO inhibitors are effective too, but they are not first-line due to their risk profile. Now let's talk about peripartum mood disturbances. These are conditions that begin during pregnancy or within 4 weeks after delivery. The risk increases in individuals with a history of mood disorders. Are you following me so far? Let's begin with the most common type, postpartum blues. It has an incidence rate of 50 to 85%, and it's characterized by a depressed affect, tearfulness, and fatigue that typically starts 2 to 3 days after delivery. Fortunately, it usually resolves within 2 weeks. Treatment is supportive, but follow-up is essential to assess for possible major depressive disorder with peripartum onset. Now listen carefully. Major depressive disorder with peripartum onset, formerly known as postpartum depression, has an incidence rate of 10 to 15%. It meets all the criteria for MDD, with onset either during pregnancy or within 4 weeks after delivery. First-line treatment includes cognitive behavioral therapy and selective serotonin reuptake inhibitors. Let's now shift to a rarer but more severe condition, postpartum psychosis. This occurs in 0.1 to 0.2% of cases, and is characterized by mood-congruent delusions, hallucinations, and disturbing thoughts of harming the baby or oneself. Are you ready for the risk factors? They include first pregnancy, a family history of psychiatric illness, bipolar disorder, any psychotic disorder, and recent medication changes. Treatment requires hospitalization and starting an atypical antipsychotic. If this approach is not sufficient, electroconvulsive therapy may be used. Speaking of ECT, electroconvulsive therapy is a rapid-acting treatment option for refractory depression, depression with psychotic features, catatonia, and acute suicidality. It induces a tonic-clonic seizure under controlled anesthesia and neuromuscular blockade. Now listen carefully to the side effects, which may include disorientation, headache, and partial anterograde or retrograde amnesia, usually resolving within 6 months. There are no absolute contraindications, and it is considered safe for pregnant individuals and older adults. Are you following me? Now let's shift our focus to suicide risk. The SAD person's mnemonic helps identify risk factors. These include sex, specifically male, age, either young adults or older adults, depression, and previous suicide attempt, which is the highest risk factor. We also include ethanol or drug use, rational thinking loss as seen in psychosis, sickness or chronic medical illness, having an organized plan, being without a spouse or social support, and stating a future intent to die. These individuals are more likely to die from suicide. In the United States, the most common method is firearms, and access to guns significantly increases the risk of suicide death. While women attempt suicide more often, men are more likely to die from it. Other important risk factors include recent psychiatric hospitalization and a family history of suicide death. Now listen closely to the protective factors. They include effective treatment for comorbid medical and psychiatric conditions, strong connections with family, community, or culture, religious beliefs that encourage self-preservation, and strong problem-solving skills. Let's shift our section into anxiety disorders. These involve inappropriate experiences of fear or worry, along with physical symptoms that don't match the size or seriousness of the actual stressors. Importantly, these symptoms must not be due to another psychiatric or medical condition like hyperthyroidism or substance use. Now are you ready to hear what's included under anxiety disorders? They encompass panic disorder, phobias, generalized anxiety disorder, selective mutism, illness anxiety disorder, obsessive-compulsive disorder, and post-traumatic stress disorder. Now let's talk about panic disorder. This condition is marked by recurrent panic attacks, which involve intense fear and discomfort, with or without a known trigger. These attacks typically reach their peak within 10 minutes, and they include at least 4 of the following symptoms: palpitations, paresthesias, depersonalization or derealization, abdominal distress or nausea, intense fear of dying, intense fear of losing control, lightheadedness, chest pain, chills, choking, sweating, shaking, or shortness of breath. It has a strong genetic component and significantly increases the risk of suicide. Now listen carefully. Diagnosis requires at least one panic attack followed by 1 month or more of one or more of the following: persistent concern about additional attacks, worrying about the consequences of an attack, or behavioral changes related to the attacks. All these symptoms represent systemic manifestations of fear. For treatment, cognitive behavioral therapy, SSRIs, and venlafaxine are first-line options. Occasionally, benzodiazepines may be used in acute settings. Are you following me so far? Then let's move on to phobias. Phobias are defined as severe, persistent fear or anxiety, lasting 6 months or more, due to the presence or anticipation of a specific object or situation. The affected person often realizes their fear is excessive, but still feels overwhelmed. Treatment relies on cognitive behavioral therapy with exposure therapy. Now, within phobias, there's social anxiety disorder, where a person experiences an exaggerated fear of embarrassment in social situations, like public speaking or using public restrooms. The treatment here includes CBT, SSRIs, and SNRIs. Are you ready for the next variation? For the performance-only subtype, where anxiety is restricted to situations like public speaking, beta blockers or benzodiazepines may be used as needed. Next is agoraphobia, which involves irrational fear, anxiety, and avoidance triggered by facing or anticipating two or more specific situations. These include public transportation, open or closed spaces, lines or crowds, or being outside of home alone. The fear often stems from the thought that help or escape might not be available. It's commonly associated with panic disorder, and the recommended treatment is CBT and SSRIs. Now listen carefully. Generalized anxiety disorder is defined by excessive anxiety and worry about various aspects of daily life, such as work, school, or children. These worries must be present on most days for 6 months or more. In adults, diagnosis requires at least 3 of the following, and in children, at least 1, difficulty concentrating, restlessness, irritability, muscle tension, fatigue or low energy, and sleep disturbance. You can remember this with the acronym CRIMES. Treatment includes CBT, SSRIs, and SNRIs as first line. Buspirone, tricyclic antidepressants, and benzodiazepines are second-line options. Now let's shift our attention to obsessive-compulsive disorders. These include obsessions, recurring intrusive thoughts or sensations that cause severe distress, and compulsions, repetitive, often time-consuming actions that relieve the distress. These disorders are associated with tic disorders, and poor insight into one's beliefs or actions tends to predict worse outcomes. Treatment starts with CBT and SSRIs. Clomipramine and venlafaxine are considered second-line treatments. Now listen carefully. Under this category is body dysmorphic disorder. Body dysmorphic disorder involves a preoccupation with minor or imagined defects in appearance, leading to significant emotional distress and repetitive behaviors like mirror checking or excessive grooming. It's especially common in individuals with eating disorders, and the best treatment is CBT. Another condition under this umbrella is trichotillomania. This is the compulsive pulling out of one's hair, causing significant distress, and it persists despite multiple attempts to stop. It typically presents with patches of thinning hair or baldness on any area of the body, most commonly the scalp. Now let's talk about how it appears. The remaining hair shafts are of varying lengths, which distinguishes it from alopecia. The incidence is highest in childhood, but it spans all ages. Treatment, once again, involves CBT and SSRIs. Now let's talk about trauma and stress-related disorders. First up is adjustment disorder, which involves emotional or behavioral symptoms like anxiety or outbursts that occur within 3 months of an identifiable psychosocial stressor, such as divorce or illness. These symptoms typically last less than 6 months after the stressor ends and do not meet the criteria for any other psychiatric illness. However, if the symptoms persist for more than 6 months after the stressor has ended, it's important to reevaluate for other explanations, like major depressive disorder or generalized anxiety disorder. Treatment begins with CBT as the first-line option, though antidepressants and anxiolytics may be considered when necessary. Now listen carefully, because post-traumatic stress disorder, or PTSD, is next. This condition follows experiencing, witnessing, or discovering that a loved one has gone through a life-threatening situation, such as serious injury or sexual assault. Symptoms include persistent hyperarousal, avoidance of associated stimuli, intrusive re-experiencing of the event through nightmares or flashbacks, and changes in cognition or mood like fear, horror, or distress. The acronym HARD, hyperarousal, avoidance, re-experiencing, and distress, can help you remember the core features. This disturbance lasts longer than 1 month and causes significant distress or functional impairment. First-line treatments include CBT, SSRIs, and venlafaxine, while prazosin can be helpful in reducing nightmares. Are you following me? Because next we have acute stress disorder, which is similar to PTSD but has a shorter duration, lasting between 3 days and 1 month. The treatment for this disorder is CBT, and pharmacotherapy is usually not indicated. Now let's transition into personality disorders, which are defined by inflexible, maladaptive, and rigidly pervasive patterns of behavior that cause subjective distress or impaired functioning. The individual is typically unaware of the problem, meaning the disorder is egosyntonic. These patterns usually emerge by early adulthood, and it's important to contrast them with personality traits, which are non-pathologic and enduring patterns of perception and behavior. Now let's organize these disorders into 3 clusters. Cluster A is known as weird and includes odd or eccentric personalities with an inability to develop meaningful social relationships. There's no psychosis, but there is a genetic link to schizophrenia. Cluster B is called wild and features dramatic, emotional, or erratic behavior, with genetic associations to mood disorders and substance use. Cluster C, or worried, encompasses anxious or fearful behavior with a genetic tie to anxiety disorders. Let's take a deeper look, starting with Cluster A. Are you ready? Cluster A includes paranoid personality disorder, which presents as pervasive distrust, constant suspicion, hypervigilance, and a deeply cynical worldview. Then there's schizoid personality disorder, marked by a preference for social withdrawal and solitary activities, with limited emotional expression and indifference to others' opinions, making them seem aloof. Lastly, schizotypal personality disorder is characterized by eccentric appearance, odd beliefs or magical thinking, and interpersonal awkwardness. It's included on the schizophrenia spectrum, and should be pronounced schizotypal to reflect the odd-type thoughts. Now let's move on to Cluster B. This group begins with antisocial personality disorder, defined by a disregard for the rights of others, lack of remorse, and behaviors like criminality, impulsivity, hostility, and manipulation. It's more common in males, and the diagnosis requires the patient to be at least 18 years old, with evidence of conduct disorder before age 15. If the patient is under 18, the diagnosis is conduct disorder. Then there's borderline personality disorder, which involves unstable moods and relationships, fear of abandonment, impulsivity, self-mutilation, suicidality, and a chronic sense of emotional emptiness. This is more common in females, and splitting is a key defense mechanism. The best treatment is dialectical behavior therapy. Now listen carefully. Histrionic personality disorder features attention-seeking behavior, dramatic speech, shallow and labile emotions, and sexually provocative actions. These individuals may use their physical appearance to draw attention and are often flamboyant. Narcissistic personality disorder is next, with features like grandiosity, a strong sense of entitlement, lack of empathy, and a need for excessive admiration. These individuals often demand the best and react to criticism with rage or defensiveness. Despite appearing confident, they have fragile self-esteem and are frequently envious of others. Now we turn to Cluster C, starting with avoidant personality disorder, which is marked by hypersensitivity to rejection and criticism, social inhibition, timidity, feelings of inadequacy, and a desire for relationships, unlike schizoid personality disorder, where such desire is absent. Then we have obsessive-compulsive personality disorder, defined by a preoccupation with order, perfectionism, and control. Unlike OCD, this is egosyntonic, meaning the behavior aligns with the person's own beliefs and attitudes. Finally, there's dependent personality disorder, characterized by an excessive need for support, submissiveness, low self-confidence, and a tendency to remain in abusive relationships due to clinginess and fear of abandonment. Now let's begin with a group of disorders where the relationship between symptoms and intention becomes very important. First, malingering involves symptoms that are intentional, and motivation that is also intentional. The patient consciously fakes, or profoundly exaggerates, or claims to have a disorder in order to attain a specific secondary, or external, gain such as avoiding work or obtaining compensation. These patients usually show poor compliance with treatment or follow-up of diagnostic tests, and importantly, the complaints typically cease after the gain is achieved. This is in contrast to factitious disorder, which we'll talk about next. Are you ready? Because now we move to factitious disorders, where symptoms are intentional, but the motivation is unconscious. In these cases, the patient consciously creates physical and/or psychological symptoms, but the goal is to assume the sick role and to get medical attention and sympathy, which is a primary or internal gain. Let's dive a little deeper. Factitious disorder imposed on self, formerly called Munchausen syndrome, is a chronic condition marked by predominantly physical signs and symptoms. The patient often has a history of multiple hospital admissions and shows a surprising willingness to undergo invasive procedures. It's more common in females and healthcare workers. Now listen carefully. Factitious disorder imposed on another, formerly known as Munchausen syndrome by proxy, occurs when illness in an individual being cared for, most often a child but also seen in disabled or older adults, is directly caused by the caregiver, such as physically harming the child, or fabricated, such as lying about the child's symptoms. This is considered a form of child or elder abuse, and it is a serious and urgent issue in medical settings. Now let's talk about somatic symptom and related disorders. In this category, symptoms are unconscious, and motivation is also unconscious. These are disorders characterized by physical symptoms that cause significant distress and impairment, but the symptoms are not intentionally produced or feigned. Let's begin with somatic symptom disorder, which involves one or more bodily complaints like abdominal pain or fatigue that last for months to years. These complaints are associated with excessive and persistent thoughts and anxiety about the symptoms. The patient may also have a co-occurring medical illness. Treatment includes regular office visits with the same physician, with the goals of addressing active symptoms, reassuring the patient, and avoiding unnecessary tests or medications. Now we move to conversion disorder, also called functional neurologic symptom disorder. This condition involves unexplained loss of sensory or motor function, such as psychogenic non-epileptic seizures, paralysis, blindness, or mutism, often following an acute stressor. The patient may be aware of the symptoms but appear indifferent to them, a phenomenon known as labile indifference. It's more common in females, adolescents, and young adults. These cases often present dramatically and require careful, empathetic evaluation. Are you following me? Because next is illness anxiety disorder, where there is a preoccupation with acquiring or having a serious illness, often despite thorough medical evaluation and repeated reassurance. The key here is that there are minimal to no actual somatic symptoms, but the anxiety about illness remains intense and persistent. Now listen carefully, because we'll wrap this up with a summary table comparing malingering, factitious disorder, and somatic symptom disorders. In malingering, symptoms are intentional and motivation is intentional. In factitious disorder, symptoms are intentional but motivation is unconscious. And in somatic symptom disorders, both the symptoms and the motivation are unconscious. Now let's talk about eating disorders, which are most common in young women. We begin with anorexia nervosa, where there is an intense fear of weight gain, an overvaluation of thinness, and a distorted body image that leads to severe calorie restriction and profound weight loss. This results in an inappropriately low body weight, defined as a BMI less than 18.5 kilograms per square meter for adults. Physiological disturbances may show up as bradycardia, hypotension, hypothermia, hypothyroidism, osteoporosis, lanugo, and amenorrhea. That last one happens because low-calorie intake leads to reduced leptin, then reduced GnRH, which lowers LH and FSH, and finally lowers estrogen, resulting in amenorrhea. Are you following me? Because there are two main types of anorexia. The binge eating or purging type involves recurring purging behaviors like laxative or diuretic abuse, or self-induced vomiting, or episodes of binge eating, all occurring over the last 3 months. This type is often associated with hypokalemia. On the other hand, the restricting type is when the primary disorder behaviors include dieting, fasting, and excessive exercise, with no purging or binge eating during the past 3 months. Refeeding syndrome is a serious risk here. It happens in severely malnourished patients who suddenly increase calorie intake, which causes a spike in insulin, followed by dangerous drops in phosphate, potassium, and magnesium, leading to cardiac complications, rhabdomyolysis, and seizures. Treatment focuses on nutritional rehabilitation, psychotherapy, and sometimes the use of olanzapine. Now listen carefully as we shift to bulimia nervosa. This involves recurring episodes of binge eating along with compensatory purging behaviors, happening at least once a week over the past 3 months. The BMI is typically normal or slightly overweight, unlike anorexia, where the BMI is low. It is often associated with parotid gland hypertrophy, which may show up as increased serum amylase, along with enamel erosion, Mallory-Weiss tears, electrolyte disturbances like low potassium and low chloride, metabolic alkalosis, and calluses on the back of the hand from induced vomiting, a sign known as Russell sign. Treatment involves psychotherapy, nutritional rehabilitation, and SSRIs like fluoxetine. Importantly, bupropion is contraindicated due to its increased risk of seizures in these patients. Now let's talk about binge eating disorder, where there are recurring episodes of binge eating without any purging behaviors, occurring at least once a week for the past 3 months. It increases the risk for diabetes and is actually the most common eating disorder among adults. Treatment starts with psychotherapy as the first line, while SSRIs and lisdexamfetamine may also be used. Are you ready to learn about another condition? Pica involves recurring episodes of eating non-food substances like ice, dirt, hair, or paint chips for 1 month or longer. These behaviors are not culturally or developmentally accepted as normal and may provide temporary emotional relief. Pica is especially common in children and during pregnancy. It is associated with malnutrition, iron deficiency anemia, developmental disabilities, and emotional trauma. First-line treatment includes psychotherapy and nutritional rehabilitation, while SSRIs are considered second-line. Now let's shift to gender dysphoria, which is defined as a significant incongruence between a person's gender identity and the gender they were assigned at birth. This mismatch must last more than 6 months and cause persistent distress. Individuals experience marked discomfort with their assigned gender, and this discomfort interferes with social, academic, or other important areas of functioning. Some may pursue gender affirmation across multiple domains including social, legal, and medical pathways. The term transgender refers to any individual who transiently or persistently experiences incongruence between their gender identity and assigned gender at birth. However, not all transgender individuals experience gender dysphoria, and it's important to remember, nonconformity to one's assigned gender by itself is not a mental disorder. And finally, now let's talk about sexual dysfunctions. These include a range of issues, such as sexual desire disorders like hypoactive sexual desire or sexual aversion, sexual arousal disorders such as erectile dysfunction, orgasmic disorders including anorgasmia and premature ejaculation, and sexual pain disorders like genitopelvic pain or penetration disorder. When evaluating sexual dysfunction, we consider a differential diagnosis using the mnemonic penis, psychological causes, especially if nighttime erections are still occurring, endocrine causes, like diabetes or low testosterone, neurogenic factors, including postoperative changes or spinal cord injury, insufficient blood flow, often due to atherosclerosis, and substances, such as antihypertensives, antidepressants, or alcohol. Now let's talk about sleep terror disorder, which involves periods of inconsolable terror with screaming in the middle of the night, and it's most common in children. These episodes occur during slow wave or deep sleep, which is stage N3 of non-REM sleep, and the child has no memory of the arousal episode afterward. This is different from nightmares, which happen during REM sleep and are often remembered as scary dreams. Triggers for sleep terror can include emotional stress, fever, or a lack of sleep. Thankfully, this condition is usually self-limited and resolves on its own over time. Now listen carefully as we shift to elimination disorders, which involve inappropriate urination, called enuresis, and/or inappropriate defecation, called encopresis, in individuals who should already be continent. These disorders are typically diagnosed in childhood or adolescence. Enuresis occurs at least 2 times a week for 3 months or more in children who are 5 years old or older, and it happens most commonly during sleep, also known as nocturnal enuresis. The first-line treatment includes behavioral modification techniques like scheduled voids and restricting fluids at night, along with using positive reinforcement. If those don't work, then bedwetting alarms and oral desmopressin, an ADH analog that has fewer adverse effects than imipramine, are recommended. Encopresis, on the other hand, happens at least once per month for at least 3 months in children who are 4 years old or older. It can occur with or without constipation and may involve overflow soiling. Treatment includes behavioral therapy, structured toilet training, and the use of laxatives or enemas when constipation is a factor. Are you following me? Because now we move to narcolepsy, which is characterized by excessive daytime sleepiness despite the person awakening feeling well rested. These individuals experience recurrent episodes of rapid onset, overwhelming sleepiness, happening at least 3 times a week for the last 3 months. The underlying cause is decreased production of orexin, also called hypocretin, in the lateral hypothalamus, which results in dysregulated sleep-wake cycles. Narcolepsy is associated with several key features: hypnagogic hallucinations, which occur just before falling asleep, and hypnopompic hallucinations, which occur just before waking up. Think of getting pumped up in the morning. Patients may also have nocturnal and narcoleptic sleep episodes that begin directly in REM sleep, and they may experience sleep paralysis. One striking symptom is cataplexy, which is a sudden loss of all muscle tone triggered by strong emotional stimuli, such as laughter. Treatment focuses on good sleep hygiene, including scheduled naps and a regular sleep schedule, combined with daytime stimulants like modafinil, solriamfetol, pitolisant, or amphetamines, and possibly nighttime sodium oxybate, also known as GHB. Now listen carefully as we wrap up with substance use disorder, which involves a maladaptive pattern of substance use, requiring the presence of at least 2 specific behaviors or symptoms within the past year. These include tolerance, withdrawal, intense and distracting cravings, using more or using for longer than intended, a persistent desire but inability to cut down, and spending excessive time acquiring, using, or recovering from the substance. It can also involve impaired functioning at work, school, or home, along with social or interpersonal conflicts, reduced recreational activities, more than one episode of use in dangerous situations, like unsafe sex or driving while impaired, and continued use even when the person is fully aware of the harm it causes. However, it's important to remember that when someone is being treated with appropriate prescribed medications, such as opioid analgesics, sedatives, or stimulants, the presence of tolerance and withdrawal alone does not qualify as a substance use disorder. Now let's explore gambling disorder, which is defined as persistent, recurrent, and problematic gambling behavior that cannot be better explained by a manic episode. The diagnosis is confirmed if the patient meets 4 or more of the following criteria: the person is preoccupied with gambling, or they require increasing amounts of gambling to reach the desired level of excitement. They may have made repeated, unsuccessful efforts to limit, cut back, or stop gambling, and they often become restless or irritable when attempting to do so. Gambling is sometimes used as a way to escape or relieve feelings of helplessness, guilt, anxiety, or depression. And after losing money, the person continues gambling in an attempt to recover the losses. They might lie to conceal the extent of their gambling, put at risk, or lose, significant relationships, careers, or academic opportunities, and may even rely on others to fix the financial collapse caused by their gambling. The treatment for this disorder is psychotherapy. Are you ready to move on? Because now we shift to the trans-theoretical model of change, which outlines the different stages involved in modifying behavior. First is the pre-contemplation stage, where the individual denies the problem and its consequences. Here, motivational strategies involve encouraging introspection, using the patient's personal priorities to explain risks, and affirming your availability. Next is the contemplation stage, where the individual acknowledges the problem but remains ambivalent or unwilling to change. In this stage, it's helpful to discuss the pros of changing and the cons of maintaining current behavior, while suggesting supportive means for behavior change. Now listen carefully, because the third stage is preparation or determination, where the person is committed to and planning for behavior change. Motivational strategies include using motivational interviewing, encouraging initial steps, promoting expectations for positive results, and providing planning resources. After that comes the action or willpower stage, where the individual executes a plan and starts demonstrating real behavioral change. Here, strategies include boosting self-efficacy, managing contingencies, and helping them cope with situations that might trigger old habits. And then we have the maintenance stage, where new behaviors are sustained and begin to integrate into the person's identity and lifestyle. In this phase, it's crucial to reinforce these developing habits, evaluate and reduce the risk of relapse, and continuously praise the progress made. Finally, there's the relapse stage, which involves regression to prior behavior, though it does not always happen. The approach to relapse varies depending on the severity of the regression, but the key is to encourage a return to change and provide reassurance that transformation is still possible. Now let's talk about psychiatric emergencies, which involve several serious conditions requiring prompt recognition and treatment. First, serotonin syndrome occurs due to any drug that increases serotonin, including psychiatric drugs such as MAO inhibitors, SSRIs, SNRIs, TCAs, vilazodone, bortioxetine, and buspirone. Non-psychiatric drugs can also cause it, like tramadol, ondansetron, triptans, linezolid, MDMA, dextromethorphan, meperidine, and St. John's wort. The syndrome presents with the 3 A's, increased activity involving neuromuscular symptoms such as clonus, hyperreflexia, hypertonia, tremor, or seizures, autonomic instability including hyperthermia, diaphoresis, and diarrhea, and altered mental status. Treatment involves benzodiazepines and supportive care, while cyproheptadine, a 5-HT2 receptor antagonist, is used if symptoms do not improve. Prevention is important, so avoid simultaneous serotonergic drugs and allow a washout period between them. Moving on, hypertensive crisis results from eating tyramine-rich foods like aged cheeses, cured meats, wine, and chocolate while taking MAO inhibitors, or from an insufficient washout period when switching antidepressants to or from MAO inhibitors. Tyramine displaces neurotransmitters such as norepinephrine in the synaptic cleft, leading to increased sympathetic stimulation and a hypertensive crisis. The treatment of choice is phentolamine. Now listen carefully to neuroleptic malignant syndrome, which is caused by antipsychotics, more commonly typical than atypical types, often with a genetic predisposition. This malignant fever syndrome stands for myoglobinuria, fever, encephalopathy, unstable vitals, increased enzymes like creatine kinase, and muscle rigidity described as lead pipe. The treatment includes dantrolene, dopaminergic agents such as bromocriptine or amantadine, benzodiazepines, and discontinuation of the causative agent. Are you following me? Because delirium tremens occurs with alcohol withdrawal, typically 2 to 4 days after the last drink, especially in hospitalized patients who cannot drink. It presents with altered mental status, hallucinations, autonomic hyperactivity, anxiety, seizures, tremors, psychomotor agitation, insomnia, and nausea. The recommended treatment is longer-acting benzodiazepines. Next, acute dystonia arises from antipsychotics, again, typical more than atypical, anticonvulsants like carbamazepine or metoclopramide. It involves sudden onset of muscle spasms, stiffness, or oculogeric crisis within hours to days after starting the medication. Severe cases may lead to laryngospasm requiring intubation. Treatment involves benztropine or diphenhydramine. Now let's talk about lithium toxicity, which occurs with increased lithium dosage, reduced renal elimination due to acute kidney injury or medications affecting clearance such as ACE inhibitors, thiazide diuretics, or NSAIDs. Lithium has a narrow therapeutic window. Symptoms include nausea, vomiting, slurred speech, hyperreflexia, seizures, ataxia, and nephrogenic diabetes insipidus. Treatment requires discontinuing lithium, aggressive hydration with isotonic sodium chloride, and consideration of hemodialysis. Finally, tricyclic antidepressant toxicity results from TCA overdose, leading to sedation, anticholinergic effects, and prolonged QT and QRS intervals. The classic triad is convulsions, coma, and cardiotoxicity due to sodium channel inhibition. Treatment is supportive, with close ECG monitoring, sodium bicarbonate to prevent arrhythmias, and activated charcoal for decontamination. Let's talk about psychoactive drug intoxication and withdrawal symptoms. Now let's begin with the depressants, which generally cause mood elevation, reduced anxiety, sedation, behavioral disinhibition, and respiratory depression during intoxication, while withdrawal symptoms include anxiety, tremor, seizures, and insomnia. Starting with alcohol, it acts as a GABA-A receptor positive allosteric modulator and also inhibits glutamate-induced excitation at NMDA receptors. Intoxication presents with emotional lability, slurred speech, ataxia, coma, and blackouts. A key lab clue is an AST value that is twice the ALT value, remember it with toast to alcohol. Treatment is supportive, involving fluids and antiemetics. Withdrawal happens due to upregulated glutamate receptors and excess excitation, so treatment involves longer-acting benzodiazepines. Now listen carefully as we go through the withdrawal timeline in hours after the last drink. Between 0 and 12 hours, tremors, insomnia, diaphoresis, agitation, and gastrointestinal upset appear. Between 12 and 48 hours, patients may experience withdrawal seizures and alcoholic hallucinosis, usually visual. And from 48 to 96 hours, delirium tremens can occur, which is potentially fatal and demands immediate care. Now moving to barbiturates, which are also GABA-A receptor positive allosteric modulators. They have a low safety margin and can cause marked respiratory depression. Treatment involves symptom management, including assisted respiration and blood pressure support. Withdrawal from barbiturates can cause delirium and life-threatening cardiovascular collapse. Now let's talk about benzodiazepines, which act on the same GABA-A receptor, but have a greater safety margin than barbiturates. Intoxication may cause ataxia and minor respiratory depression. Flumazenil, a benzodiazepine receptor antagonist, is the treatment. Withdrawal may present with seizures, sleep disturbance, and depression. Now listen carefully to opioids, which modulate opioid receptors. Mu receptor activation is responsible for classic effects like miosis or pinpoint pupils, reduced gastrointestinal motility, respiratory and CNS depression, euphoria, reduced gag reflex, and seizures. Opioids are the most common cause of drug overdose death. Overdose is treated with naloxone. Withdrawal symptoms include mydriasis, diarrhea, flu-like symptoms, rhinorrhea, yawning, nausea, sweating, piloerection or cold turkey, and lacrimation. Management involves symptomatic care, and medications such as methadone or buprenorphine. Are you following me? Because inhalants are next. They work by enhancing GABA signaling. Intoxication leads to disinhibition, euphoria, slurred speech, ataxia, disorientation, drowsiness, and a characteristic periorifical rash. Onset is rapid, and resolution is just as quick. Withdrawal symptoms include irritability, dysphoria, sleep disturbance, and headaches. Now let's talk about stimulants, which nonspecifically elevate mood, reduce appetite, cause psychomotor agitation, insomnia, cardiac arrhythmias, increased heart rate, and anxiety during intoxication. Withdrawal brings a post-use crash, marked by depression, lethargy, increased appetite, sleep disturbance, and vivid nightmares. Now finally, amphetamines, which act by inducing reversal of monoamine transporters, VMAT, DAT, SERT, and NET, leading to increased neurotransmitter release. Intoxication presents with euphoria, grandiosity, mydriasis, prolonged wakefulness, hyperalertness, hypertension, paranoia, and fever. Methamphetamine use often causes skin excoriations, while severe cases can result in cardiac arrest or seizures. Treatment involves benzodiazepines for agitation and seizures. A unique symptom to remember is meth mites, which are tactile hallucinations. Now let's continue with caffeine, which acts as an adenosine receptor antagonist. Intoxication can lead to palpitations, agitation, tremor, and insomnia. When withdrawn, symptoms may include headache, difficulty concentrating, and flu-like symptoms. Are you ready to talk about cocaine? It blocks the reuptake of dopamine, serotonin, and norepinephrine by inhibiting DAT, SERT, and NET transporters. Intoxication features impaired judgment, mydriasis, diaphoresis, hallucinations including formication, paranoia, angina, and even sudden cardiac death. Chronic use can lead to a perforated nasal septum, caused by vasoconstriction and ischemic necrosis. Treatment includes benzodiazepines. Withdrawal symptoms include restlessness, hunger, severe depression, and sleep disturbance. Now listen carefully as we explore nicotine, which stimulates central nicotinic acetylcholine receptors. Intoxication primarily presents with restlessness. Withdrawal symptoms are more prominent and include irritability, anxiety, restlessness, decreased concentration, and increased appetite or weight. Treatment options include nicotine replacement therapies such as patches, gum, or lozenges, and also medications like bupropion or varenicline. Now let's talk about hallucinogens, starting with lysergic acid diethylamide, or LSD, which acts as a 5-HT2A receptor agonist. Its intoxication leads to perceptual distortion, both visual and auditory, depersonalization, anxiety, paranoia, psychosis, flashbacks, and mydriasis. Withdrawal effects are not typically noted, but psychological effects may linger. Next comes cannabis and cannabinoids, which work as CB1 receptor agonists. Intoxication includes euphoria, anxiety, paranoid delusions, a perception of slowed time, impaired judgment, social withdrawal, increased appetite, dry mouth, conjunctival injection, and hallucinations. Withdrawal symptoms may include irritability, anxiety, depression, insomnia, restlessness, and reduced appetite. Are you following me? Because MDMA, also known as ecstasy, is next. It induces reversal of monoamine transporters, SERT more than DAT or NET, resulting in increased neurotransmitter release. Intoxication can cause euphoria, hallucinations, disinhibition, hyperactivity, increased thirst, bruxism or teeth grinding, and distorted perceptions, along with mydriasis. Serious complications include hypertension, tachycardia, hyperthermia, hyponatremia, and serotonin syndrome. Withdrawal may bring depression, fatigue, appetite changes, difficulty concentrating, and anxiety. Now listen carefully to phencyclidine, or PCP, which is an NMDA receptor antagonist. Intoxication is characterized by violence, nystagmus, impulsivity, psychomotor agitation, tachycardia, hypertension, analgesia, psychosis, delirium, and seizures. Have you heard about alcohol use disorder, which is diagnosed using the criteria for substance use disorder? Complications can include vitamin B1 deficiency, alcoholic cirrhosis, hepatitis, pancreatitis, peripheral neuropathy, and testicular atrophy. Treatment options include naltrexone, which reduces cravings but should be avoided in liver failure, acamprosate, which is contraindicated in renal failure, and disulfiram, which conditions the patient to abstain from alcohol use. Support groups, such as Alcoholics Anonymous, are helpful in sustaining abstinence and supporting both the patient and the family. Now listen carefully as we discuss Wernicke-Korsakoff syndrome, which results from vitamin B1 deficiency. Symptoms can be precipitated by administering dextrose before vitamin B1. The classic triad includes confusion, ophthalmoplegia, and ataxia, which are signs of Wernicke encephalopathy. This condition may progress to irreversible memory loss, confabulation, and personality change, known as Korsakoff syndrome. Treatment involves intravenous vitamin B1, and it must be given before dextrose to prevent worsening symptoms. Are you ready to shift to psychotherapy? Let's talk about behavioral therapy first. It teaches patients how to identify and change maladaptive behaviors or reactions to stimuli, such as using systematic desensitization for specific phobia. Cognitive behavioral therapy teaches patients to recognize distortions in their thought processes, develop constructive coping skills, and reduce maladaptive coping behaviors, promoting greater emotional control and tolerance of distress, for example, recognizing triggers for alcohol consumption. Now let's talk about dialectical behavioral therapy, which is designed for use in borderline personality disorder, but can also be used in other psychiatric conditions, including depression. Interpersonal therapy focuses on improving interpersonal relationships and communication skills. Motivational interviewing enhances intrinsic motivation to change by exploring and resolving ambivalence. It is used in substance use disorder and weight loss. Finally, supportive therapy utilizes empathy to help individuals during a time of hardship, maintaining optimism or hope. Now listen carefully as we finish with central nervous system stimulants, including methylphenidate, dextroamphetamine, methamphetamine, and lisdexamfetamine. Their mechanism involves increasing catecholamines in the synaptic cleft, especially norepinephrine and dopamine. They are clinically used for ADHD, narcolepsy, and binge eating disorder. Adverse effects can include nervousness, agitation, anxiety, insomnia, anorexia, tachycardia, hypertension, weight loss, tics, and bruxism. Antipsychotic medications, starting with typical, or first-generation, antipsychotics, these include haloperidol, pimozide, trifluoperazine, fluphenazine, thioridazine, and chlorpromazine. Now moving to atypical, or second-generation, antipsychotics, these include aripiprazole, asenapine, clozapine, olanzapine, quetiapine, iloperidone, paliperidone, risperidone, lurasidone, and ziprasidone. Their mechanism involves blocking dopamine D2 receptors, which increases CMP. Atypical antipsychotics also block serotonin 5-HT2 receptors, and notably, aripiprazole is a D2 partial agonist. Now listen carefully as we discuss their clinical uses. These drugs are used for schizophrenia, where typical antipsychotics primarily treat positive symptoms, and atypical antipsychotics treat both positive and negative symptoms. They are also used in disorders with concomitant psychosis, like bipolar disorder, Tourette syndrome, obsessive-compulsive disorder, and Huntington disease. Clozapine is reserved for treatment-resistant psychotic disorders or those with persistent suicidality. Remember this with the phrase, close to the edge. Are you following me? Let's now explore their adverse effects. They include antihistaminic effects like sedation, anti-alpha-1 adrenergic effects like orthostatic hypotension, and antimuscarinic effects such as dry mouth and constipation, collectively remembered as anti-JM. Caution is advised when used in dementia. Metabolic side effects include weight gain, hyperglycemia, and dyslipidemia, with higher risk observed in clozapine and olanzapine, which are associated with obesity. Endocrine effects include hyperprolactinemia, leading to galactorrhea, oligomenorrhea, and gynecomastia, due to reduced activity in the tuberoinfundibular pathway. Now let's talk about the cardiac and neurologic risks. These medications can cause QT prolongation, and serious neurologic complications like neuroleptic malignant syndrome. Ophthalmologic concerns include corneal deposits from chlorpromazine, and retinal deposits from thioridazine. Clozapine carries additional risks, agranulocytosis, requiring close monitoring of white blood cells, seizures that are dose-related, myocarditis, and hypersalivation. These effects are important to recognize for safe management. Now listen carefully, as we dive into extrapyramidal symptoms, which stem from reduced activity in the nigrostriatal pathway, and can be remembered using the acronym ADAPT. In the first few hours to days, acute dystonia may appear, with muscle spasm, stiffness, or oculogeric crisis, and treatment includes benztropine or diphenhydramine. In the days to months range, akathisia may occur, characterized by restlessness, and treated with beta blockers, benztropine, or benzodiazepines. Also in this time frame, Parkinsonism may develop, showing as bradykinesia, and treated with benztropine or amantadine. Over months to years, tardive dyskinesia can appear, often with chorea, especially in the orofacial region, and treatments include benzodiazepines, botulinum toxin injections, valbenazine, or deutetrabenazine. You should remember this: these drugs are lipid-soluble, meaning they are stored in body fat, and therefore, they are slow to be removed from the body. Typical antipsychotics have greater affinity for D2 receptors than atypical ones, which leads to increased risk for hyperprolactinemia, extrapyramidal symptoms, and neuroleptic malignant syndrome. Among the typicals, high-potency drugs include haloperidol, trifluoperazine, pimozide, and fluphenazine. Just recall, how tries pi to fly high, these tend to cause more neurologic adverse effects. Meanwhile, low-potency typicals include chlorpromazine and thioridazine. Remember, cheating thieves are low, these have more antihistaminic, anti-alpha-1 adrenergic, and antimuscarinic effects. Let's continue with lithium, a well-known mood stabilizer. Its mechanism involves affecting neurotransmission by reducing excitatory signals and increasing inhibitory ones, while also influencing second messenger systems, such as G proteins. It is used clinically as a mood stabilizer for bipolar disorder, helping treat acute manic episodes and preventing relapse. Now listen carefully as we explore its adverse effects. These include tremor, hypothyroidism, and even hyperthyroidism in some cases, along with mild hypercalcemia. It can cause polyuria by inducing nephrogenic diabetes insipidus, and is teratogenic. Most notably, it can lead to abstain anomaly in the fetus. Because lithium has a narrow therapeutic window, close monitoring of serum levels is essential. It is almost exclusively excreted by the kidneys, and most of it is reabsorbed at the proximal convoluted tubule via sodium channels. Are you following me? This means that drugs affecting renal clearance, like thiazide diuretics, ACE inhibitors, and NSAIDs, can increase the risk of lithium toxicity. You should remember the mnemonic, lithium, where L stands for low thyroid, meaning hypothyroidism, T for heart, referring to abstain anomaly, I for insipidus, indicating nephrogenic diabetes insipidus, U for unwanted movements, pointing to tremor, and M for movements again, emphasizing its motor side effects. Now let's switch gears and talk about buspirone. It works through a completely different mechanism, as a partial agonist at the 5-HT1A receptor. It's primarily used for generalized anxiety disorder, and here's the good news, it doesn't cause sedation, addiction, or tolerance, which makes it safer for long-term use compared to other anxiolytics. However, its therapeutic effects don't begin immediately, it usually takes about 1 to 2 weeks to start working. Are you ready for another helpful tip? Unlike barbiturates or benzodiazepines, buspirone does not interact with alcohol, making it a safer option for patients who may occasionally consume alcohol. And here's a memorable phrase to help lock it in, I get anxious if the bus doesn't arrive at 1, so I take buspirone. Now let's talk about antidepressants, which typically require 4 to 8 weeks before showing an appreciable effect. Among the most commonly prescribed are the selective serotonin reuptake inhibitors, or SSRIs, and these include fluoxetine, fluvoxamine, paroxetine, sertraline, escitalopram, and citalopram. Their mechanism involves inhibiting the reuptake of serotonin, or 5-HT, which helps elevate mood over time. Clinically, SSRIs are used to treat depression, generalized anxiety disorder, panic disorder, obsessive-compulsive disorder, bulimia, binge-eating disorder, social anxiety disorder, PTSD, premature ejaculation, and premenstrual dysphoric disorder. You should remember this, although SSRIs have fewer adverse effects than tricyclic antidepressants, they are not without concerns. Adverse effects include serotonin syndrome, gastrointestinal distress, syndrome of inappropriate antidiuretic hormone secretion or SIDH, and sexual dysfunction, such as anorgasmia, erectile dysfunction, and reduced libido. Also, be aware that in individuals with underlying bipolar disorder, SSRIs may precipitate a manic episode. Now let's explore serotonin norepinephrine reuptake inhibitors, or SNRIs. These include venlafaxine, desvenlafaxine, duloxetine, levomilnacipran, and milnacipran. Their mechanism of action involves inhibiting the reuptake of both serotonin and norepinephrine, which boosts their levels in the brain. These medications are used to treat depression and generalized anxiety disorder, and are also effective in diabetic neuropathy. Venlafaxine is specifically indicated for social anxiety disorder, panic disorder, PTSD, and OCD, while duloxetine and milnacipran are also indicated for fibromyalgia. Are you following me? The adverse effects of SNRIs include increased blood pressure, stimulant effects, sedation, sexual dysfunction, and nausea. Now moving on to the tricyclic antidepressants, these include amitriptyline, nortriptyline, imipramine, desipramine, clomipramine, doxepin, and amoxapine. TCA work by inhibiting the reuptake of serotonin and norepinephrine, similar to SNRIs, but with more side effects. Now listen carefully as we examine their uses and risks. TCA are used in major depressive disorder, peripheral neuropathy, chronic neuropathic pain, and migraine prophylaxis. Clomipramine is used specifically for OCD, and imipramine for nocturnal enuresis. Adverse effects include sedation, alpha-1 blocking effects like postural hypotension, and anticholinergic symptoms such as tachycardia, urinary retention, and dry mouth. Tertiary TCS like amitriptyline have more anticholinergic activity than secondary TCA like nortriptyline. You should remember this powerful mnemonic: tricyclics, convulsions, coma, and cardiotoxicity, which refers to arrhythmias due to sodium channel inhibition. Other risks include respiratory depression and hyperpyrexia. In older adults, confusion and hallucinations are more common due to anticholinergic side effects, and secondary amines like nortriptyline are better tolerated. Treatment of TCA toxicity involves administration of sodium bicarbonate to prevent arrhythmias and stabilize cardiac membranes. Now let's conclude with monoamine oxidase inhibitors, or MAOIs, which include tranylcypromine, phenelzyne, isocarboxazid, and selegiline, a selective MAOB inhibitor. Remember the phrase, MAO takes pride in Shanghai, to recall the names. These drugs work by non-selectively inhibiting monoamine oxidase, leading to increased levels of amine neurotransmitters such as norepinephrine, serotonin, and dopamine. They are used in atypical depression, anxiety, and Parkinson disease in the case of selegiline. And here's something important: you should watch out for CNS stimulation and the infamous hypertensive crisis, especially if patients ingest tyramine-rich foods. MAOIs are contraindicated with SSRIs, TTCA, St. John's wort, meperidine, dextromethorphan, pseudoephedrine, and linezolid to prevent serotonin syndrome. Always wait at least 2 weeks after stopping MAOIs before starting serotonergic drugs or ending dietary restrictions, to avoid triggering a hypertensive crisis or serotonin syndrome. Now let's talk about the atypical antidepressants, and to remember them, just say, atypical bees make tasty vegan venison. First, we begin with bupropion, which inhibits norepinephrine and dopamine reuptake. It is also used for smoking cessation. The adverse effects include stimulant effects such as tachycardia and insomnia, along with headache, and an increased risk of seizures in patients with bulimia and anorexia nervosa. However, you should remember this: bupropion has reduced risk of sexual adverse effects and weight gain compared to other antidepressants, making it a favorable choice in certain individuals. Now let's move to mirtazapine, which is an alpha-2 antagonist, increasing the release of norepinephrine and serotonin. It is also a potent antagonist at 5-HT2 and 5-HT3 receptors, and an H1 histamine receptor antagonist. Its adverse effects include sedation, which may actually be desirable in depressed patients with insomnia, and increased appetite and weight gain, which may be beneficial in underweight patients. It may also cause dry mouth. And here's a helpful phrase: mirtazapine makes you munch more and move less. Are you following me? Let's continue with trazodone, which primarily blocks 5-HT2, alpha-1 adrenergic, and H1 receptors, and weakly inhibits serotonin reuptake. It is used primarily for insomnia, because high doses are needed for antidepressant effects. Adverse effects include sedation, nausea, priapism, and postural hypotension. Just remember, trazodone, due to its sedative and male-specific adverse effects like priapism. Next up is vilazodone, which inhibits serotonin reuptake and is a partial agonist at 5-HT1A receptors. It is used for major depressive disorder. Adverse effects include headache, diarrhea, nausea, and anticholinergic effects. And importantly, it may cause serotonin syndrome if taken with other serotonergic agents. Similarly, bortioxetine also inhibits serotonin reuptake and acts as a 5-HT1A receptor agonist and 5-HT3 receptor antagonist. It is used for major depressive disorder as well. Adverse effects include nausea, sexual dysfunction, sleep disturbances, and anticholinergic effects, and again, serotonin syndrome can occur with other serotonergic drugs. Now listen carefully, we're switching to pharmacotherapies for smoking cessation. First, we have nicotine replacement therapy, which binds to nicotinic acetylcholine receptors and aims to relieve withdrawal symptoms when stopping smoking. Both long-acting patches and short-acting products like gum or lozenges can be used together. Adverse effects may include headache and oral irritation. Now let's talk about varenicline, which is a partial agonist at nicotinic acetylcholine receptors. It diminishes the effect on the reward system but also reduces withdrawal symptoms. Adverse effects include gastrointestinal discomfort and sleep disturbance. Just remember this, varenicline helps nicotine cravings decline. Now we're moving to medically supervised opioid withdrawal and relapse prevention. Injection drug use increases the risk for hepatitis B, hepatitis C, HIV, skin and soft tissue infections, bacteremia, and right-sided infective endocarditis. Methadone is a long-acting oral opioid used for medically supervised opioid withdrawal or for long-term maintenance therapy. Then there's buprenorphine, a partial opioid agonist, given sublingually as a film to suppress withdrawal and for maintenance. However, be cautious, because partial agonists can precipitate withdrawal symptoms in opioid-dependent individuals, especially when given shortly after full agonist use. And now, let's discuss naloxone, which is a short-acting opioid antagonist administered intramuscularly, intravenously, or as a nasal spray, and is used to treat acute opioid overdose, especially to reverse respiratory and CNS depression. Lastly, there's naltrexone, a long-acting oral opioid antagonist used after detoxification to prevent relapse. It may also help with alcohol and nicotine cessation, and weight loss. Just remember this, use naltrexone for the long treks back to sobriety.